So welcome students, welcome back to the class. And now as I was telling you, I will be starting with the fifth chapter, which is pediatric renal disorders. Now the three chapters which are left, pediatric renal disorders, pediatric respiratory disorders, and pediatric gastrointestinal disorders are very small topics. So as I was telling you, almost 70% of pediatrics is already completed. So if you actually go through this portion of pediatrics, which I've already completed, you can be rest assured 70 to 75% pediatrics is done. Now the remaining pediatrics is a very small part of pediatrics that remains, which includes three important topics, which is gastrointestinal disorders, respiratory disorders, and renal disorders that we'll be doing now. Before I move to renal disorders, there were a few questions that were asked, so I would like to take the opportunity to answer those questions. We'll very quickly go through these questions. The first question was on hypoplastic left heart syndrome. So a student asked me to just explain hypoplastic left heart syndrome very quickly. So I will just go through this hypoplastic left heart syndrome very quickly. When I was telling you cyanotic heart diseases associated with increased pulmonary flow, I told you cyanotic heart diseases associated with increased pulmonary flow are basically four main disorders. First is transposition of great arteries. Second is truncus arteriosus. The third is total anomalous pulmonary venous return. And the fourth was hypoplastic left heart syndrome. Now, as the name suggests, hypoplastic left heart syndrome. On the left side of the heart, what structures are there? There is a left atria. There is a left ventricle. In between the left atria and the left ventricle is the bicuspid valve or the mitral valve. And from the left ventricle starts the aorta, so the ascending aorta. So I would say on the left side of the heart, there are four main structures: the left atria, then the left ventricle, the bicuspid valve or the mitral valve, which connects the left atria and the left ventricle, and the ascending aorta. Out of these four structures, if there is hypoplasia, underdevelopment of three structures, which are those three structures? Left ventricle, then the bicuspid or the mitral valve, and the ascending aorta. Which three structures are hypoplastic? Left ventricle, mitral valve or the bicuspid valve, and the ascending aorta. So when these three structures are actually underdeveloped, we call this condition as a hypoplastic left heart syndrome. So it's understandable that when the blood will come after oxygenation from the lungs through the pulmonary vein and will enter into the left atria, it ideally should go down into the left ventricle. But because the mitral valve and the left ventricle is hypoplastic, this blood from the left atria will not be able to go down. So what is the only place it can move? It can then only move from the left atria into the right atria through the foramen ovale. Normally it does not allow foramen ovale, but because the left atria blood cannot move down into the left ventricle, the pressure in the left atria increases, causing the blood to move into the right atria, and therefore mixing of oxygenated and deoxygenated blood occurs in the right atria. That is why we call this as a cyanotic heart disease. So I hope you have understood why is this a cyanotic heart disease. So there is now in the right atria, there is superior vena cava blood, there will be inferior vena cava blood, and plus now this pulmonary vein blood has also entered into the right atria. All this blood will enter into the right ventricle and then go to the lungs. So normally how much blood goes into the lung? Only superior vena cava, inferior vena cava for oxygenation. Now how much blood is going to the lungs? Superior vena cava, inferior vena cava, and the four pulmonary veins. So obviously the amount of blood going into the lungs will increase. That is why this is a cyanotic heart disease with an increase in the pulmonary blood flow. It is one of the most common congenital heart disease associated with shock, because there is no left ventricle at all. So the moment the child will be born, there will be no pulses or very feeble pulses of the child. So this is the heart disease associated with shock and death within the first few days of life. Associated with shock and death within the first few days of life. This is hypoplastic left heart syndrome. Then there was a question on necrotizing enterocolitis. A student asked me, why is necrotizing enterocolitis, why is there obstruction occurring in the intestine? Please try to understand, necrotizing enterocolitis, there is infection of the intestine because milk is being given to a preterm very early in life. Infection to the intestine. And it is a normal phenomena that whenever there is intestinal infection, leave children, even in adults, if there is infection of the intestine, the first thing that the intestine tries to do is gradually reduce down the motility and go into a phase of stall. Stall means that the intestine will stop contracting, and the signs and symptoms of intestinal obstruction will appear. Why is there obstruction? There is no physical obstruction. But because now the intestines are not contracting, they are trying to limit this infection. If they keep on contracting, the infection which was present in the upper part of the intestine will go into the lower part of the intestine. So it's a normal phenomena, the infection, to prevent the infection from passing down into the lower part of the intestines stop contracting. And when they stop contracting, whatever milk you are giving to a child keeps on accumulating in the stomach and the upper part of intestine. So it therefore acts as a type of intestinal obstruction. There is no physical obstruction, but any type of infection of the intestine will gradually lead to a phase of intestinal obstruction. I hope this is also answered. Then there was a question if ependymoma occurs on the second and third ventricle. So I told you ependyomas occur from the lining of the ventricles. So it can occur from the lining of the lateral ventricles, third ventricle, fourth ventricle. Obviously, when it will occur from the lining of the lateral ventricles, it will become a supratentorial disorder. But majority of ependyomas, because they occur from the lining of the fourth ventricle, that is why it is called primarily as an infratentorial. It's understandable when it will occur from the lining of the lateral ventricles above the tentorium cerebelli. Any brain tumor which will be above the tentorium, even an ependyoma, when it will be above, then it will become a supratentorial brain tumor. But largely for your exams, if they ask you which of the following is an infratentorial brain tumor, ependymoma should be considered as an infratentorial brain tumor, because a large majority of them always arise from the fourth ventricle. Then there was a question, most common risk factor for neural tube defect. Well, books do not say which are the most common factor. I told you the risk factors can be infant of diabetic mothers, then mothers who take valproate, carbamazepine during pregnancy, then mothers who are deficient in zinc. So please understand, there is no specific line written that this is the most common risk factor for neural tube defect. But I think in the Indian context, infant of diabetic mothers carry probably the highest risk of developing neural tube defects. So in the Indian context, I feel infant of diabetic mothers will probably carry the highest risk. So this is the strongest risk factor. This should be considered as the strongest risk factor. But I really do not know if this is actually correct or not, because no books directly say this. For your examination purposes, yes, if the question is asked, you should say that the strongest risk factor for neural tube defects in a child is a child being born to a diabetic mother. And the last question was, a student asked me spina bifida aperta. So the student asked me spina bifida aperta. It is also sometimes called as spina bifida cystica. So remember, I told you neural tube defects can be divided up into, I told you it can be craniospinal, it can be cranial, or it can be spinal. Now, how did we further classify spinal? Spinal can be open or it can be closed. What is the other name for closed? I told you it is spina bifida occulta. The other name for open spinal neural tube defect, open, is sometimes known as spina bifida cystica or spina bifida aperta. So spina bifida aperta or spina bifida cystica is the old name that used to be given to an open type of a spinal neural tube defect. When only meninges is herniating out, then it is known as a meningocele. When both meninges and spinal cord are herniating out, then it is known as a myelomeningocele. Why I did not tell you this? Because these were old terms and are no longer used. But in case you want to ask, sir, what is a spina bifida aperta or a spina bifida cystica? It is a type of an open spinal neural tube defect. So spina bifida aperta or spina bifida cystica is of two types. When only meninges herniate out, then it is known as meningocele. When meninges and spinal cord both herniate out, then it is known as a myelomeningocele. Right? So I hope this answers all the queries that the students asked me and you are satisfied with the answers. With this, I move on to the 5th chapter now. Which is renal disorders in children. So we now talk about pediatric renal disorders or renal disorders in children. And the first thing that I would like to start with, is abdominal masses. So you need to understand that whenever there is a mass that is felt in the abdomen of a neonate, almost 60% of these masses are likely to be masses arising from the kidneys. So almost 60% of the masses that can be felt in the abdomen are actually a mass which is arising from the kidneys. So renal masses are known to form almost 60% of abdominal mass. You understand, if there is a mass which can be felt in the abdomen, 6 out of 10 times the chances are it is likely to be a mass which is arising from the kidney. Overall, the most common cause of an abdominal mass in neonates is a hydronephrosis, enlarged kidneys. So which is the most common cause of abdominal mass in a neonate? It is hydronephrosis or an enlarged kidney. The second most common cause of an abdominal mass in a neonate is a multicystic dysplastic kidney. Multicystic dysplastic kidney, please remember, also happens to be the most common congenital cystic disorder of the kidneys. There are certain congenital disorders in the kidneys. Which are known to present with cysts inside the kidneys. I will be talking about these congenital disorders in my next slide. Out of all those congenital cystic disorders, the most common congenital cystic disorder of the kidney is a multicystic dysplastic kidney. And multicystic dysplastic kidney is the second most common cause of an abdominal mass in a newborn. Which is the most common cause of abdominal mass in a newborn? Hydronephrosis. Which is the second most common cause of an abdominal mass in newborns? It is a multicystic dysplastic kidney. And which is the third most common cause of abdominal mass in newborn? It is a tumor of a kidney which is known as mesoblastic nephroma. What is the name of this tumor? Mesoblastic nephroma. Please don't confuse. If they ask you a question, which is the most common tumor of the kidney in a newborn, don't say Wilms tumor. Wilms tumor is very, very rare in newborns. The most common tumor of the kidney in a newborn is a tumor whose name is mesoblastic nephroma. And how does mesoblastic nephroma present? It presents as an abdominal mass. So which are the important causes of abdominal mass in newborns? I will only talk about 3 causes of abdominal mass in newborns, and all the 3 are known to arise from the kidneys. Which is the most common cause of abdominal mass? Hydronephrosis. Which is the second most common cause of abdominal mass? Multicystic dysplastic kidney. And which is the third most common cause of abdominal mass? It is mesoblastic nephroma. Mesoblastic nephroma is the most common tumor of the kidney in newborns. And multicystic dysplastic kidney is the most common congenital cystic disorder of the kidney. So I'll come back to this slide. So this was a question that is an FMG question that was asked in the exams. I'm sure now you can answer this question. So the FMG question was, which of these is the most common cause of abdominal mass in newborns? And the choices they had given was a horseshoe kidney, the second was and autosomal recessive polycystic kidney disease. What is the full form of ARPD? Autosomal recessive polycystic kidney disease. We'll talk about this. Then autosomal dominant polycystic kidney disease. What is the full form of ADPKD? Autosomal dominant polycystic kidney disease. And D was multicystic dysplastic kidney. This was the question that was asked in FMG. So here, as you can see, the most common cause of abdominal mass in newborns is not there, not an option. Which was the most common cause of abdominal mass? Hydronephrosis. But if hydronephrosis is not one of the options, then the next best option, the second most common cause of abdominal mass in newborns, is a multicystic dysplastic kidney. So in that case, your answer should be a multicystic dysplastic kidney. So overall most common cause of abdominal mass in newborns is hydronephrosis. But if hydronephrosis is not one of the options, then the second most common cause of abdominal mass in newborns is a multicystic dysplastic kidney. And I just now told you multicystic dysplastic kidney also happens to be the most common congenital cystic disorder of the kidney. And the third very common cause of abdominal mass in newborns is mesoblastic nephroma, which happens to be the most common tumor of the kidney in newborns. Don't say Wilms tumor. Wilms tumor is not the most common tumor of the kidney in newborns. The most common tumor of the kidney in newborns is a mesoblastic nephroma. Now just a few words now about congenital cystic disorders of the kidney. So just a few words now about congenital cystic disorders of the kidney. Now there are certain disorders I told you which can present with cysts from birth in the kidney. These are congenital disorders because most of these disorders present with cysts from birth. Now whenever you are asked name some congenital cystic disorders of the kidney, the three most important disorders that should come to your mind, which are congenital cystic disorders of the kidney, are multicystic dysplastic kidney, polycystic kidney disease, and a medullary sponge kidney. These are the three primary disorders that should come to your mind when you are asked, can you name some congenital cystic disorders of the kidney? Multicystic dysplastic kidney, polycystic kidney disease, and a medullary sponge kidney. As you can see in this picture, in a multicystic dysplastic kidney, cysts are usually randomly arranged. Random arrangement of cysts are there, but in the case of a polycystic kidney disease, cysts are usually arranged in a radial fashion. You're seeing how cysts are arranged in a radial fashion. So in a polycystic kidney disease, the cysts usually are arranged in a radial fashion. This is the characteristic of a polycystic kidney disease. In the case of a multicystic dysplastic kidney, the cysts are randomly arranged. Some large cysts, some small cysts, some large cysts, some small cysts. And see what has happened to the outline of the kidney. The kidney outline is totally damaged. You are seeing kidney outline is totally damaged. That is why the name dysplastic kidney. Usually when it occurs, it affects only one kidney. That is why sometimes multicystic dysplastic kidney is also known as unilateral renal dysplasia. What is the other name? Unilateral renal dysplasia. Because this is a disorder which usually affects a single kidney. Unilateral renal dysplasia. The other kidney may be normally functioning or may have some other co-associated disorders. But one kidney is totally damaged because of random arrangement of cysts, large cyst, small cyst, large cyst, small cyst. In fact, if you do an antenatal ultrasound, fetal ultrasound, how will the cysts appear like? Now this is an FMG question. How will the cysts appear like? These cysts will appear like a bunch of grapes or a soap bubble. So this was an FMG question, a bunch of grape appearance or soap bubble appearance. of cysts on an ultrasound will indicate which disorder? It will indicate a multicystic dysplastic kidney. You can see the cysts, how they are present. This is how they are present. So bunch of grapes appearance or soap bubble appearance, random arrangement of cysts present on an ultrasound in the fetal kidney will indicate the possibility of a multicystic dysplastic kidney. So what is this appearance known as? It is known as a bunch of grapes appearance, or it is sometimes known as the soap bubble appearance. So there is random arrangement of cysts. Usually only one kidney is affected. In contrast to a polycystic kidney disease in which usually both kidneys are affected. And the cysts are usually arranged in a radial fashion. Most of these cases of polycystic kidney disease in children are autosomal recessive in inheritance. That is why it is also known as autosomal recessive polycystic kidney disease. AR stands for autosomal recessive polycystic kidney disease. So if you are asked difference between a polycystic kidney disease, a multicystic dysplastic kidney, and a polycystic kidney disease, if you are asked the difference, multicystic dysplastic kidney usually is sporadic in occurrence. So it does not have a familial pattern. That means it does not run in families. While this is usually having a familial pattern, it runs in families. And what type of inheritance? Autosomal recessive. That is why it is sometimes also referred to as an autosomal recessive polycystic kidney disease. In short, we call it as ARPKD. What do we call it as? We call it as autosomal recessive polycystic kidney disease. Don't confuse with autosomal dominant polycystic kidney disease, which is again a polycystic kidney disease but is known to occur more commonly in adults. So if someone says this child is suffering from an infantile polycystic kidney disease, that means it is autosomal recessive. If someone says this child is suffering from an autosomal dominant polycystic kidney disease, the adult is suffering from a adult type of polycystic kidney disease, then this is autosomal dominant. So I'll repeat again. If someone says this child is suffering from an infantile polycystic kidney disease, this means this is autosomal recessive. If someone says this person is suffering from an autosomal dominant polycystic kidney disease, this is an adult type of polycystic kidney disease where the inheritance is autosomal dominant. So polycystic kidney disease in children have an autosomal recessive inheritance pattern, while polycystic kidney disease in adults have an autosomal dominant inheritance pattern. The gene which is primarily affected, which gene is primarily affected in polycystic kidney disease of children? It is PKHD1 gene. And what does HD1 stands for? HD1 stands for hepatic dysfunction. That is why whenever polycystic kidney disease occurs in newborns, there is always likely to be a co-associated hepatic fibrosis. So it is likely to be associated, co-associated hepatic fibrosis. So liver invariably is involved. Reason being that the gene that is usually mutated in this condition is a PKHD1 gene. PK stands for polycystic kidney, but HD stands for hepatic dysfunction. So liver invariably is affected in the case of a polycystic kidney disease, but in the case of a multicystic dysplastic kidney, the liver is usually normal. Then usually polycystic kidney disease usually involves bilateral, both kidneys. While this usually is unilateral and involves one kidney. Last, the arrangement of cysts. So arrangement of cysts is in a radial fashion. I told you they are arranged in a radial sequence, while arrangement of cysts here is in a random fashion. Some large cysts, some small cysts. That is why we call it as bunch of grape appearance. So both of them are polycystic kidney diseases, both of them, but there are some differences. Multicystic dysplastic kidney usually sporadic. Sporadic means it does not run in families. Polycystic kidney disease usually familial. And which type of familial? It is usually autosomal recessive. The gene that is involved in a polycystic kidney disease of children is PKHD1 gene. PK stands for polycystic kidney, HD stands for hepatic dysfunction. So liver usually is involved in these cases, liver fibrosis. But in the case of a multicystic dysplastic kidney, liver usually is normal. Then polycystic kidney disease usually is bilateral, affects both the kidneys, usually presents with both kidneys being enlarged. On the other hand, multicystic dysplastic kidney is unilateral, that means affects only one kidney. That is why I told you it is sometimes also referred to as a unilateral renal dysplasia. Finally, arrangement of cysts on an ultrasound. If the cysts are arranged in a radial fashion, then we call this as a polycystic kidney disease. But if the cysts are arranged in a random fashion, large cyst, small cyst, large cyst, small cyst, we call this as a multicystic dysplastic kidney. And because of the random arrangement of cysts, usually we say the soap bubble appearance, or it is also called as the bunch of grapes appearance on an ultrasound. So someone asks you bunch of grapes appearance on an ultrasound or soap bubble appearance on an ultrasound, is usually indicative, fetal ultrasound is usually indicative of which disorder? It indicates the presence of a multicystic dysplastic kidney. I just now received a question from what age can we do lumbar puncture? See, lumbar puncture is done even in neonates to identify neonatal meningitis. So lumbar puncture to take out the CSF can be done at any age. It is done even in newborns to identify neonatal meningitis. Okay, so I hope you have understood the differences between these two disorders. The third types of congenital cystic disorder is known as a medullary sponge kidney. This is the third one, medullary sponge kidney. Why is a medullary sponge kidney known as medullary sponge kidney? Because there are cysts which are present in the renal medulla. Can you see the cysts present in the renal medulla? The blue colored, thick blue colored arrow, it is showing you the cysts which are present in the renal medulla. This outer portion is known as the cortex, and this inner portion is known as the medulla of the kidneys. So you can see the cortex appears to be normal, but the medulla, the pyramids inside contains cysts. That is why we call it as cysts in the renal medulla, medullary sponge kidney. It usually is not diagnosed very early in life. So among the congenital cystic disorders, we typically take multicystic dysplastic kidney and a polycystic kidney disease. A medullary sponge kidney, although maybe a congenital disorder, can be detected as late as the adolescent period. So it may remain asymptomatic throughout the childhood period. So I think for your exams, you should focus only on these two congenital cystic disorders. So I'll repeat the differences once again. Multicystic dysplastic kidney, which is the most common congenital cystic disorder. This is the type of disorder which is not familial. Polycystic kidney disorder usually is familial. Which type of inheritance? Autosomal recessive. The gene which is involved in polycystic kidney disease, because it is familial, that means gene is involved. So it is PKHD1 gene. PK stands for polycystic kidney, HD stands for hepatic dysfunction gene. On the other hand, multicystic dysplastic kidney usually does not have any gene involvement, hence it is not a familial disorder. Polycystic kidney disease usually affects both kidneys. Both kidneys are enlarged. On the other hand, multicystic dysplastic kidney usually affects one kidney. It is also therefore known as unilateral renal dysplasia. The arrangement of cysts is also important. Cysts are arranged in a radial fashion in the case of a polycystic kidney disease, while cysts are arranged in a random fashion in the case of a multicystic dysplastic kidney. And this random arrangement of cysts is why we call it as a bunch of grapes or a soap bubble appearance on fetal ultrasound. So if a fetal ultrasound is done and the kidneys show the presence of this type of appearance, we say the child most likely is suffering from a multicystic dysplastic kidney. Medullary sponge kidney, which is the third type of disorder, I will not go into the details, but just one thing that you need to know is when an intravenous pyelography, IVP stands for intravenous pyelography. When an intravenous pyelography is done, it shows a typical paintbrush appearance. Paintbrush appearance, also sometimes known as a bouquet of flower appearance in the case of a medullary sponge kidney. So what is an IVP test? In an IVP test, we give a dye intravenously. This dye goes inside the body and then collects in the renal medulla. So the dilated cysts take up the dye and therefore it appears as if there is head of a paintbrush. You can see the head of a paintbrush appearance. This is the head of a paintbrush appearance. So on an intravenous pyelography, a paintbrush appearance or a bouquet of flower appearance. Either we call it as a paintbrush appearance or we call it as a bouquet of flower appearance. Should indicate to a medullary sponge kidney. So regarding the multicystic dysplastic kidney, you should remember the sign which is seen on ultrasound, which is the soap bubble appearance or the bunch of grape appearance. But in the case of a medullary sponge kidney, you should see the sign on an IVP, intravenous pyelography, which is paintbrush appearance or a bouquet of flower appearance. Just a word about Porter's syndrome. Now, Porter's syndrome is a syndrome which is associated with bilateral renal agenesis. Please hear first what I am saying, then you can write. Please hear this. In 1962, around 1962, there was appearance of certain cases of a child born with certain abnormalities, and the primary abnormality which was present in the child was both kidneys of the child were not properly developed. These other abnormalities were considered to be part of the abnormality of renal agenesis. That means the primary abnormality was renal agenesis, both renal agenesis, both kidneys not developed, and other problems were associated with this problem. These problems were grouped under a syndrome which was known as the Porter syndrome. So Porter syndrome, the primary abnormality is bilateral renal agenesis. But what are the other problems that can be associated with Porter syndrome? So there will be a pulmonary hypoplasia. So P stands for pulmonary hypoplasia. O stands for oligohydramnios. T stands for twisted skin. So there will be wrinkles present on the skin. Another T stands for twisted fascias. So there will be abnormal fascias. E stands for extremity defects. And then all of them are associated with bilateral renal agenesis. So what are the features of Porter syndrome? P-O-T-T-E-R. P stands for pulmonary hypoplasia. O stands for oligohydramnios. T stands for twisted skin. Twisted skin means there are wrinkles present on the skin of these infants. Then another T stands for twisted facies. You can see the abnormal Porter's facies. A very broad nasal bridge is there. Our nasal bridge is very narrow. These children have very broad nasal bridge. So T stands for twisted skin and another T stands for twisted facies, which means abnormal facies. E stands for defects in the extremities. You can see the defects in the extremities. You can see the defect in the extremities, defects in the extremities. And then all of this is occurring because of bilateral renal agenesis. So Porter syndrome is associated with bilateral renal agenesis. P stands for pulmonary hypoplasia, O stands for oligohydramnios, T stands for twisted skin, T stands for twisted facies, E stands for extremity defects, and all of this is occurring because of bilateral renal agenesis. Right? So what is the syndrome called? It is known as Porter syndrome. So someone asks you Porter syndrome is associated with, you will say bilateral renal agenesis. The next topic we will do is urinary tract infection in children. Now please, before you start writing, please pay attention to what I am saying first. Please don't start writing suddenly. Please pay attention to what I am saying. See, urinary tract infection in children is not a very common phenomenon. Whatever UTIs occur in children, majority of them occur because of a congenital disorder which is known as a Psycho-Uretric reflux. Now what is a Psycho-Uretric reflux? Please try to understand this. This is the kidneys, this is the ureter, then you have the bladder, and then you have the urethra. Now this is the bladder, this is the Vesico-ureteric junction. Vesico is bladder, ureteric is ureter. So the junction between the ureter and the bladder. Normally, as you must be knowing, there is always a one-way flow of urine from the ureter down to the bladder. But in some children, either this orifice, the Vesico-ureteric junction is not properly developed, or there is some other physiological abnormality, as a result of which, when the child applies pressure on the bladder, the urine, rather than flowing down into the urethra, starts refluxing up into the ureter and may actually go right up into the kidney. This type of a reflux, which is starting from the bladder and is going back into the kidneys, can be a very, very important cause of a kidney damage in a young child. The kidneys can start getting scarred and can ultimately get damaged. What is this condition called? This condition is known as a Psycho-Uretric reflux. In short, it is also called as a VUR. So VUR is a congenital disorder which results in a retrograde flow of urine. Retrograde, it's not antigrade, it is retrograde flow of urine from the bladder up into the ureter and the kidneys, leading to recurrent urinary tract infections. It's very easy to understand. If there will be again and again urine from the bladder going up into the kidneys, the bladder urine may contain infection, and this will allow the infection to go up and enter into the kidneys again and again. This will ultimately cause scarring in the kidneys and may cause total kidney damage. We have seen children who are 3 years, 4 years of age presenting with total kidney damage, end-stage renal disease, because for the last 3 years they had been having recurrent urinary tract infections, and the physician or the pediatrician was seeing just used to give antibiotics and treat that urinary tract infection, but he never cared to find out what was the underlying cause of UTI. UTI, if you treat now, will occur again after 2 months, because there is a continuous reflux of urine which is happening from the bladder to the ureter. So the problem is not a urinary tract infection, problem is what is causing that urinary tract infection. And what is causing that urinary tract infection? A Psycho-Uretric reflux. So that is why all young children who have a urinary tract infection, there should be some investigations done in all these children to find out whether they have an underlying Psycho-Uretric reflux or not. Because if you do give antibiotics to a child for a urinary tract infection, antibiotics gets treated, you will feel happy that I have treated this condition. But after 2 months, infection will occur again. You treat that infection, another 2 months, this infection will occur again, because you are not caring to find out what is the underlying cause of this recurrent UTI, which is Psycho-Uretric reflux. So one of the most common causes of recurrent UTI in young children is a Psycho-Uretric reflux. And therefore, all young children who are having urinary tract infection or who are having recurrent urinary tract infection, we should always try to do certain investigations to find out whether they have a Psycho-Uretric reflux or they have any damage to the kidneys because of a Psycho-Uretric reflux. So what are the investigations we do? What are the investigations we do? So the first investigation that we do is an ultrasound of the kidney to see whether the kidneys are getting enlarged or not. That is a sign of pyelonephritis, infection of the kidney. The second test that we do is a test which is known as MCU. What is the full form of MCU? Micturating Cysto-Ureterogram. Now this is the test which is a gold standard test to identify VUR. So which is the gold standard test to identify a Psycho-Uretric reflux? It is micturating Cysto-Ureterogram. It is sometimes also called as VCUG. What is the full form? Voiding Cysto-Ureterogram. Voiding Cysto-Ureterogram. So either you say micturating Cysto-Ureterogram or you say voiding Cysto-Ureterogram, both of them are the same thing. So which is the first investigation you do when a child is having a urinary tract infection? See an ultrasound of the kidney just to see whether the kidneys have got damaged from outside or not. They have started to enlarge in size or not. In pyelonephritis, they will start to increase in size. Second test, do a micturating Cysto-Ureterogram, also known as a voiding Cysto-Ureterogram. And the third test that you would like to do in this case is to do a Dmsa scan. A Dmsa scan is a radionuclide scan. I think your radiology faculty must have told you it's a radionuclide scan which is used to identify structural damage to the kidney, like scars in the kidney. So structural damage to the kidney. An ultrasound will be able to show you the kidney from outside. It will not be able to show you whether the kidney has been damaged from inside or not. The structural damage to the kidney from inside can be shown by a radionuclide scan which is known as a Dmsa scan. So which are the three investigations we'll do? We'll do an ultrasound, we'll do a micturating Cysto-Ureterogram, also sometimes called as a voiding Cysto-Ureterogram, and we'll do a Dmsa scan. So these are the three investigations that should be done in these children to identify a VUR or damage to the kidney because of a BUR. So it's like this. Please see this. It's like this. Do you do all investigations in a child? No. Please follow this approach. Whenever there is a first urinary tract infection in a child, what investigations are to be done out of these three will depend upon what is the age of the child. So suppose the first UTI occurs in a child who is less than 1 year, investigations will be different. Suppose it occurs in a child who is between 1 to 5 years, investigation will be different. And suppose it occurs in a child who is more than 5 years, investigation will be different. In a child who has a UTI and the child's age is less than 1 year, you have to do all the three investigations. You have to do the ultrasound of the kidneys, ultrasound of the abdomen to see whether kidneys are normal or not. You have to do a Dmsa scan also, and you have to do a micturating cysto-ureterogram also. So any child who is less than 1 year of age and has a urinary tract infection, all the three should be done. Now, when a child is between 1 to 5 years of age, there is no need of doing all the three. So what you will do is, you will do an ultrasound and you will do a Dmsa scan. Don't do an MCU initially. If an ultrasound or a Dmsa scan are normal, there is no abnormality, then do not do anything. So nothing else needs to be done. But suppose these are abnormal, so there is some abnormality that is noted in these scans. In that case, then you perform a micturating cysto-ureterogram. You understand? So in a child who is between 1 to 5 years, there is no need of performing all the tests together. In a child who has a UTI and the child is between 1 to 5 years of age, first perform an ultrasound and a Dmsa scan. If the scans are normal, nothing else needs to be done. There is no need of performing a MCU. But if the scans are abnormal, then yes, an MCU should be performed, because suppose the scans are showing there are scars in the kidney, the kidneys have got enlarged, that means kidney damage is occurring because of a reflux. Then you have to confirm reflux. In that case, do an MCU. If the child is more than 5 years and for the first time the child has a UTI, then only an ultrasound needs to be performed first. If the ultrasound is normal, nothing else needs to be done. But if the ultrasound is abnormal, then you do the other two tests, which are MCU and USG. I hope there is no confusion. I'll repeat again. Depending upon the age of the child, you decide whether all the three tests needs to be done, these three tests, all these three tests need to be done, or selective tests needs to be done. So suppose there is a child who has a first UTI when the child was less than 1 year of age. There is no thinking about it. You have to do all the three investigations. You have to do ultrasound, you have to do a Dmsa scan, you have to do an MCU. Suppose the child had a UTI when the child was between 1 to 5 years of age. He may be a 2-year-old child, he may be a 3-year-old child, he may be a 4-year-old child. At this time he had a first UTI. Don't perform an MCU initially, perform an ultrasound and a Dmsa scan. Ultrasound normal, Dmsa scan results are normal. Nothing else needs to be done. However, if these results are abnormal, then you perform an MCU. And suppose the child is more than 5 years of age, and this time he has a UTI. In a 7-year-old child, for example, first time UTI occurs. Only an ultrasound needs to be performed initially, nothing else. And if the result of an ultrasound is normal, kidney is normal, no problem is seen in the kidneys, you will not do an MCU or a Dmsa scan. But suppose the results are abnormal after 5 years of age, results of ultrasound. In that case, then you have to perform an MCU and a Dmsa scan. I'll write it here again because I think you might not be able to understand everything. So I'll write it here again. First UTI, less than 1 year, 1 to 5 years, more than 5 years. Less than 1 year, perform all the three tests: ultrasound, DMSA, and MCU. 1 to 5 years, perform an ultrasound and perform a DMSA. If the results are normal, nothing else needs to be done. But if the results are abnormal, in that case, you perform a MCU. More than 5 years, only initially perform an ultrasound. If the results are normal, nothing else needs to be done. But if the results are abnormal, then you need to perform an MCU and a Dmsa scan. So this is how you will identify which all investigations will be performed in case the child has a urinary tract infection. Out of these three tests, ultrasound, DMSA and MCU, the gold standard test for identifying a Psycho-Uretric reflux is the micturating cysto-ureterogram. So suppose they ask you a question in the exam. There is a 4-year-old child with a urinary tract infection. Which of these is the investigations you should perform initially? 4-year-old child with a UTI. Which is the investigation you should perform? So if the child is 4 years of age, the child will be in this group. So which investigation should be performed in a 4-year-old child with UTI initially? Which investigation should be performed? Choice A, only ultrasound. Choice B, ultrasound and a DMSA. Choice C, ultrasound and a MCU. Choice D, ultrasound, DMSA, MCU. So he is 4-year-old child. Answer will be ultrasound and DMSA should be performed initially. 7-year-old child with a UTI. Which investigation should be performed initially? 7-year-old child. Ultrasound, ultrasound and DMSA, ultrasound and MCU, ultrasound, DMSA and MCU. 7-year-old child is there, so child will be in this group. So child will be in this group. So which investigation is to be performed? You need to perform a micturating cysto. You need to perform an ultrasound only first. Yes, if ultrasound is abnormal in a 7-year-old child, then you will perform an MCU and a DMSA. Right? So I hope you have understood this. This is an MCU. So you actually, how is a micturating cysto-ureterogram performed? So you take a tube, usually a feeding tube is taken in a very small child, and this feeding tube is then passed through the urethra. You can see the feeding tube pass through the urethra. So you pass a feeding tube through the urethra, and then you push a dye through this tube. So you can see the dye is collecting in the bladder. Just see the second arrow, the dye is collecting in the bladder. Can you see this dye going up into the ureters? No, you cannot see. So this is a normal MCU which does not show a Psycho-Uretric reflux. So it does not show a Psycho-Uretric reflux. However, this is the next, which shows you that there is a massive. You can see how much of dye is going up into the ureters and how much of dye has entered into the kidney. So dye has not only entered into the bladder, but has started going up into the ureters and into the kidneys as well. So this is a micturating cysto-ureterogram which is showing a Psycho-Uretric reflux. Okay. Then I was telling you about certain radionuclide scans. Radionuclide scans. Then we were about radionuclide scans. So radionuclide scans, DMSA scan, DTPA scan. DMSA scan is basically a scan which is done for identifying a structural abnormality in the kidney, while a DTPA scan is usually done to identify functional abnormalities in the kidney. And which abnormality does a DTPA scan look for? It looks for abnormalities in the glomerular filtration rate. So while a DMSA scan is for identifying any structural abnormality in the kidney, the DTPA scan is a scan which is used to identify functional abnormalities in the kidney. There is another scan which is known as the MAC3 scan. This scan is also a radionuclide scan, is also a scan to identify functional abnormality in the kidney. And which abnormality does it look for? It looks for abnormalities in the renal plasma flow. So two scans to identify structural abnormalities. Two scans to identify functional abnormalities, one scan to identify structural abnormality. Which is the scan which is used to identify structural abnormality? It is the DMSA scan. Which is the scan which is used to identify functional abnormalities? It is DTPA scan and the MAC3 scan. The DTPA scan is for identifying abnormality in the glomerular filtration rate, while the MAC3 scan is a scan which is used to identify abnormality in the renal plasma flow. Now, I was telling you one of the most common causes of urinary tract infection, especially recurrent urinary tract infection in children, is the Psycho-Uretric reflux. So just a few things to learn about Psycho-Uretric reflux. See, Psycho-Uretric reflux is a retrograde reflux of urine from the bladder up into the kidney. So it is normally always a one-way flow from the kidneys down to the bladder. Whenever there is a retrograde reflux of urine from the bladder up into the kidneys, this is known as a Psycho-Uretric reflux. So from the bladder, this urine is refluxing up into the kidneys. It is not going down, it is going up. And again, it will allow the infection to enter into the kidneys, causing damage to the kidneys. Now, please remember this congenital disorder, Psycho-Uretric reflux. It's a congenital disorder. This congenital disorder is familial in inheritance. That means it runs in families. It's an autosomal dominant disorder and is much more commonly seen in females in comparison to males. So this is a very important question. Is Psycho-Uretric reflux more commonly seen in males? No, it is more commonly seen in females. What is the typical inheritance pattern? The typical inheritance pattern is autosomal dominant. So an older child in the family had a Psycho-Uretric reflux. The chances are the next child in the family may again have a Psycho-Uretric reflux. So it's a disorder which runs in families. And which is the best way to identify a Psycho-Uretric reflux? I told you the gold standard test to identify a Psycho-Uretric reflux is known as the micturating cysto-urethrogram. It is also known as VCUG, voiding cysto-urethrogram. This is the gold standard test to identify a Psycho-Uretric reflux. Okay, Psycho-Uretric reflux, it can occur because of two reasons. Either there is a defect in the development of the urinary tract. Now there is no other abnormality in the urinary tract, but the urinary tract is not properly developed. This type of Psycho-Uretric reflux is known as a primary Psycho-Uretric reflux. So it is not occurring secondary to any problem. It is a defect in the development of